Good noon. So, distinguished delegates, guests, ladies and gentlemen, I'm Jagat Narula. I'm the president of the World Heart Federation. It is my great honor and pleasure to welcome you all today on behalf of the World Heart Federation to our event entitled Advancing Cardiovascular Health for All through National Action Plans. Cardiovascular disease is responsible for 1 in 3 deaths globally, a staggering toll that continues to rise despite being largely preventable. A recent analysis by the World Heart Federation found that only 16 out of 193 countries currently have a valid, dedicated national cardiovascular health strategy or action plan. In stark contrast, a 218 review of national cancer control plans identified 92 such plans across 158 countries. That is a difference from 7.5% to 75%, a tenfold better action plans by the cancer groups. In most cases, CVD is addressed through broader non-communicable disease strategies or general national health plans. While this integrated approach has merits, it often lacks the specificity, visibility, and resourcing needed to effectively reduce cardiovascular morbidity and mortality. We believe that the time has come to change that. A dedicated national cardiovascular health action plan not only elevates cardiovascular disease on the political and policy agenda, but also enables countries to prioritize interventions, streamline policies, and mobilize the necessary funding for a coordinated response. When thoughtfully designed and effectively implemented, such plans can significantly improve cardiovascular outcomes and contribute meaningfully to achieving Sustainable Development Goal Target 3.4, reducing premature mortality from NCDs by 1/3. The framework you will hear about today is a global, adaptable guide to support countries in developing their own national cardiovascular disease action plans. Our goal is not to prescribe a one-size-fits-all solution, but to provide a robust yet fixable model that countries can tailor to their unique context, capacity, and cardiovascular burden. CVD is not a single disease. It encompasses a diverse range of conditions, from coronary artery disease to heart failure, rheumatic heart disease, Chagas disease, each shaped by different risk factors, social determinants, and health system responses. The framework, therefore, encourages a nuanced, context-specific approach, empowering governments to craft plans that reflect their national epidemiological profiles and population needs. This is only the beginning. This framework is a living document, and we are committed to working closely with countries and partners to ensure its relevance, feasibility, and practical implementation. In the lead up to the United Nations high-level meeting on NCDs in 2025 September, we have a critical window of opportunity to elevate cardiovascular health on the global agenda. The World Heart Federation was proud to present our prioritized recommendations to the recent multi-stakeholder hearing, and today's event builds on that momentum. By advancing national cardiovascular health action plans, we aim to contribute meaningfully to global non-communicable disease commitments and ensure that cardiovascular disease receives the focused attention it urgently requires. Before I conclude, I would like to express our sincere thanks to MSD for their invaluable support in making this event possible. Thank you very much. And Janelle, if I could request you to, floor is yours. Thank you.
Good afternoon. Thank you for everyone that's here, distinguished guests, colleagues. My name is Janelle Krishnamurthy, and I represent MSD today as head of global policy. I also, as a researcher, my first grant was in the Department of Nephrology, looking at salt sensitivity with African American teenagers and seeing how they may be at risk for cardiovascular disease. And lastly, as a daughter who's had a father who has dealt with cardiovascular disease. Merck is a company, MSD, outside of the US and Canada, is dedicated to using the power of leading-edge science to save and improve lives around the world. It's an honor to welcome you here to this event hosted by the World Heart Federation to explore how we can improve cardiovascular health across the globe. We're convening at this very critical time in public health. As we recall, during COVID, we were all focused on infectious disease. We know NCDs and cardiovascular health didn't go away. If anything, the time is now, it's increased. And during this time, as we're looking at the World Health Assembly and then building to September at the UN General Assembly, we need to make sure there is actually action that comes, not just more declarations, but actual action. Cardiovascular disease remains the leading cause of death across the globe, with over 20 million deaths annually. That's roughly equal to losing a population of a city the size of Beijing or Mumbai. Most of these deaths are caused by heart attack or stroke and by preventable risk factors such as cholesterol or blood pressure. Unfortunately, these aren't the sexy things, right? It's the basics, right? In addition to the human health of costs of death and disability, the economic burden of cardiovascular disease is substantial for our healthcare system, for society, for patients, and their families. While challenge is significant, the right commitment, political will, and partnerships are essential, and we can build a future where fewer people are suffering from heart disease. A key strategy of this is the development and implementation at a national cardiovascular health action plans. Implementation is really a key. We can't just rest, which it's so hard to develop these plans. And as was just said, they need to be individualized so they work for the community and the countries that are there. But we also have to make sure it follows through to the actual implementation. And that is where we have governments that are able to prioritize cardiovascular disease, allocate the resources, and enable the monitoring of progress. This can foster the collaboration and promote the comprehensive strategies across the continuum of the disease that will improve the health outcomes for communities. While competing priorities, and we understand budgets are tight, there's wars that are going on, there's a lot of geopolitical unrest, but ultimately, we need to look at health as an investment and instead of a liability. You know, there have been stats that said if we would allocate the appropriate amount of funds against the top 5 NCDs, which includes cardiovascular, that in 2030, we would save over $47 trillion to this global economy. That is 20 times more than the global health budget. That's also 60 million lives. This is a good investment, and that is why it's essential that we're not just talking, which are great, our health ministers, but we also need to be closing the sector with also our finance ministers as well, and bringing the economy and the economic case to this. So as MSD, we are proud to be your partners. We want to be true partners with you. And over the decades of engagement, I feel like our research has led to some groundbreaking therapies and have changed the way we care for heart health. And we're going to continue doing that. And so we believe that by continuing to innovate and work together, we can make a real difference on this burden of cardiovascular health. So I'd like to thank the World Health Federation for bringing us together at this critical time for this important discussion where we will have to engage on the urgency and purpose of this work. So I look forward to the insights and the collaboration. And this is as a partner from MSD and as a daughter who has a father that's going to celebrate his 85th birthday next week. But he had a heart attack 30 years ago. And to think if he did not have all the care he did, he would not be hiking 10 miles a week and seeing his 4 grandchildren now that are 13 years old and 9 and 10 and living the life that we feel really fortunate. And I hope that we can ensure people all over the world have access to this healthcare and this innovative treatment. So it's now my pleasure to invite Finn Jarl Rode, the CEO of the World Heart Federation, to introduce the World Heart Federation's framework for a cardiovascular health action plan. Thank you.
Thank you so much, Janelle. Thank you, MSD, for hosting or for being here together with us and make this opportunity. I'll tell you something before I start. My name is Finn. The next one I don't use because it's so difficult for anyone outside Norway. I am completely new to the World Heart Federation. So forgive me, I will read my speech, which I normally would never do, but today I will. I saw the framework this morning, so also forgive me for not having sort of in-depth understanding. But what I want to tell you is that I worked for International Red Cross for 25, almost 30 years. I worked with global health program all over the world. So the 25 years was outside Geneva. Only the last years was in Geneva. So I have a little bit of experience into what we do on the ground. How is the field work and how is the implementation? How is the dialogue with the local community, with the regional community, and with Ministry of Public Health? As Janelle said, it's very difficult, it's challenging, because we are all screaming for the same money or crying for the same money. I always said, I'm an official beggar. I've been there for 25 years. My main role for the Red Cross was to talk to government and ask for support. There be money or technical capacity or whatever. It doesn't matter, you know. But then we come into only the health area, which is one of many big ones. And the way we work, and I really refer today to the sort of structural crisis that we have with UN, but also very many other agencies will feel that, not only today, but tomorrow and the coming years. More and more so. We will not see a restructured WHO, a restructured development and humanitarian sort of organizational map around the globe in many years. And I think it will not come back to what it was, but maybe also tomorrow bring something new, something more energizing, and something more understandable for all parties. So what we do with the framework is to have a tool which are more focused in dialogue, in making policies, and in making opportunity to sort of build up cardiovascular health in front of the government, to say the importance, to not to reiterate on the numbers, but the numbers are extreme compared to, you know, what we can do. It's preventable. We have all the opportunities in our hand. But of course, we also know that other NCDs will say the same. So it is a competition. In the competition, we have to be good, we have to be forward-leaning and saying this is what we want. But then we have to be focused, and that is what we try. So I will read out this, a little bit on why, a little bit on who and how, and a short conclusion in the end. So, thank you. Many governments recognize the importance of cardiovascular health, but they don't know where to start, or they lack technical guidance on how to build a national strategy that is feasible, integrated, and aligned with existing priorities. Cardiovascular disease is complex, but the solutions aren't mysterious. They're well known, cost-effective, and in many cases already recommended in global targets, such as the WHO's NCD, Best Buys, or the Global Hearts Initiative. Our framework is designed to help governments bring all of that together, to elevate CVD as a national priority. It provides a clear and unified direction to move beyond fragmented efforts toward a coordinated, whole-of-government response. With a national plan in place, policies become more consistent, funding can be more effectively targeted, and intervention can be scaled with greater efficiency. In short, it creates the condition for more strategic investment, smarter resource allocation, and ultimately, measurably, better health outcomes for the population. Just as importantly, the framework is adaptable. It's not a checklist to be copied and pasted. It's a living guide that countries can tailor based on their burden of disease, their health system capacity, and their development goal. Who is it for? The primary audience is policymakers, especially Minister of Health, who are responsible for health planning, budgeting and progress implementation, but also national heart foundations, cardiology societies, NGOs that are advocating for the prioritization of cardiovascular health and offering technical expertise. Finally, development partners, including WHO, PAHO, the World Bank, and others, can use this framework to support the design and implementation of national cardiovascular health action plans in a way that is both locally relevant and globally aligned. The structure of the framework. We have structured the framework on detailed action organized across 9 core components. Governance and leadership. Political commitment is the foundation of any health strategy. Without it, plans don't get funded or implemented. A national cardiovascular plan needs clear leadership, a dedicated coordinating body, and a place in national health and development agendas. Risk factor prevention and health promotion. Most heart disease starts with modifiable risk factors: tobacco use, unhealthy diets, physical inactivity, and harmful use of alcohol. The framework encourages countries to use regulation, fiscal policy, and public awareness campaigns to tackle the root cause of poor heart health. Screening and early detection. Many people with high blood pressure or early signs of heart disease go undiagnosed for years. That's why simple, community-based screening for hypertension, diabetes, and cardiovascular risk should be core function of primary health care. Acute care and treatment. When someone has a heart attack or stroke, minutes matter. But in many settings, patients can't reach care in time or arrive to find facility lacks the capacity to treat them. We therefore need to implement standardized treatment protocols based on clinical guidelines, expand access to essential therapies, those proven treatments that can prevent deaths and complications, both in emergency and over long term. It is also important to ensure that these medicines and diagnostics are affordable and covered under universal health coverage. Without that, millions of people remain unable to get the care they need when they need it the most. Access to medicine and technologies. Essential medicine like anticoagulants, statins, and antihypertensives should be available in every health center. Yet in many low-income countries, they're missing from the shelves or too expensive for patients. Our framework urges countries to review national essential medicine list, support pooled procurement, and improve supply chain logistics. All necessary steps to achieving universal health coverage. Rehabilitation and secondary prevention. After a heart event, patients need support to avoid another one. A strong plan includes the training of healthcare providers on post-stroke, post-heart attack, and heart failure rehab protocols, and integrates secondary prevention into primary care, ensuring patients don't fall through the cracks after discharge. Health financing and sustainability. CVD care must be financially protected, not just for governments, but for patients. There are two critical steps government can take. They should allocate dedicated funding for cardiovascular disease prevention and care within national health budgets. These signals that CVD is a true priority. Second, they need to expand insurance coverage so that essential services like medication, screening, and rehabilitations are included. That's how we reduce out-of-pocket cost and make care accessible to everyone, not just the wealthy. Data, surveillance, and research. Without data, we can't set targets. We can't monitor progress or hold system accountable. The framework emphasizes the need for robust registries, strengthening health information system to collect reliable disaggregated data on CVD burden and risk factors. Promoting the use of WHO Global Health and PEN protocols for CVD risk assessment and management. The last one, equity and social determinants of health. Finally, and this is critical, cardiovascular disease is not just a medical issue. It's shaped by poverty, by gender, geography, and structural inequities. The framework urges a whole-of-society approach, ensuring that CVD services are accessible at the primary healthcare level. This reduces disparities between urban and rural areas where distances and infrastructure can limit access. Plans should also proactively identify and engage population less likely to use health services, whether due to gender norms, geographic isolation, or financial barriers. Moreover, social protection policies must be developed or strengthened to provide financial and healthcare support for CVD patients, reducing out-of-pocket costs and protecting families from catastrophic health expenditure. To translate these strategic priorities into lasting change, it is essential to secure sustainable and equitable financing mechanisms that underpin cardiovascular health services. Securing sustainable financing for cardiovascular health requires embedding CV services within national health insurance scheme. By actively involving insurers in developing cardiovascular health action plan, country can ensure that prevention and treatment services are included in beneficiaries' coverage, budgeting, resource allocation, and reimbursement mechanism. To reduce financial barrier for underserved population, policy reform must address the high cost of medicine and diagnostic. Tools like public procurement reforms, price regulation, and pooled purchasing across region can enhance affordability and, again, lower out-of-pocket expenses. Generating sustainable domestic funding also calls for innovating health promoting taxes on products harmful to cardiovascular health, such as tobacco, alcohol, sugar-sweetened beverages, and unhealthy foods. Environmental taxes like carbon or landfill taxes can be additional revenue resources, redirected, subsidized from fossil fuels toward healthier initiative, including subsidized for nutritious food, can further strengthen cardiovascular health financing. Finally, these financing strategies should again align with broader health and development goals, such as addressing other non-communicable diseases, aging population, multimorbidity, and preparedness for pandemics or shocks. To ensure that these plans are more than paper commitments, the framework also provides guidance for implementation and monitoring. Effective implementation and monitoring of cardiovascular health action plans demand a structured approach that tracks progress, ensures accountability, and drives meaningful outcomes. This begins early in the implementation phase, utilizing routine health information system to provide timely and commitment by integrating CV health objectives into national health strategies, allocating sufficient budget, and maintaining stakeholder engagement. Secondly, tracking health outcomes by monitoring reductions in CVD risk factors, controlling blood pressure and cholesterol, and decreasing incidence and mortality rates. Third, strengthening healthcare system through training healthcare workers and ensuring availability of essential medicines. And finally, ensuring equitable access by measuring service coverage across population, disaggregated by age, gender, socio-economic status, and geography. Together, these components enable countries to assess progress systematically and adapt strategies to achieve equitable and sustainable cardiovascular health improvements. Conclusion. It's preventable, but it needs planning. It's a big document. It's many words. It's wide, in terms of, I think, giving it to you like this. What was said by my president before, it's a draft in working. And that's why we shared today, because we can have that sort of open discussion. But I think it's not only a health issue, as you said, General. It's social and it's economic. And we have to be prepared to fight for our ground to make this to implementation. Not only these words this morning or afternoon, but something that can actually be taken. And we know we have all been there so many times, but at least I can assure you this is part of my job. I will never let it go. I will fulfill and see that this comes into real action. And that's why I assured you in the beginning of my speech that I have that capacity. I've done this before, and I will do it again. And thank you for MSD to be part of this. Thank you so much.
Thank you very much indeed to all our speakers for laying out the importance of national cardiovascular health action plans, and thank you, Finn, for laying out the framework and some of the tenets of the framework. I'm Shuli Ghosh. I'm going to be taking us through the session from here on in as we build on what we've heard from Jagat and Janelle and Finn and look in more detail at the practicalities of implementing and sustaining and developing national health plans specifically for cardiovascular disease. We have a brilliant panel of speakers who'll be sharing their perspectives with us, and they're also going to be taking questions from the floor, so you can quiz them on whatever aspects of cardiovascular health that you want to. So I'm going to bring them onto stage and introduce them to you now. So we have Dr. Renan Sukmawan, head of the Indonesian Cardiology and Vascular Medicine Board and board member of the Indonesian Heart Foundation. Please take a seat next to me. Good to see you. Thank you very much indeed for being here. Esther Medina Bermejo, Head of Public Health in the General Directorate of Public Health and Health Equity at Spain's Ministry of Health. Dr. Kuomivi Agboyebo, Medical Officer, Cardiovascular Diseases, Communicable and Non-Communicable Diseases at the WHO. Good to see you too. And Dr. Neil Johnson, Executive Director of Global Heart Hub, an alliance of heart patient organisations. Welcome to all of you to this beautiful venue. So we are going to drill down a little bit into national health plans for cardiovascular disease. And Renan, let me start with you, because Indonesia doesn't have a standalone cardiovascular health action plan, but you do have an NCD health action plan, and cardiovascular diseases is a key plank of that. Just explain for all of us, how does that ensure that heart health is prioritised within your national policies?
Okay, can you hear me? Anyone? I have to stand up?
No, you don't
Okay,
have to.
no.
Please, take it easy. Sit
Okay.
down. We're here for a while.
Okay, okay. First of all, thank you, everyone. Thanks for having me here with some of colleagues there. So, actually, Indonesia now is already doing what we call true action plans, in which our government involved very much and spending lots of billion on that. So, after the COVID, then our Minister of Health has chance to focusing more on NCDs. So we have part of our transformation, health transformation. There are at least 5 areas right now in national referral transformation, including cancer, stroke, cardiovascular disease, stroke, uronephrology, and motherhood and child health. So our government, working with us, for example, part of board of cardiology, and my colleagues there, board of heart surgery. So we try to increase access. You know, Indonesia having 17,000 islands, right?
Yeah.
17,000 islands, difficult access. So yeah, we can have, for example, a good public medical center everywhere, but once the patient detected having cardiovascular disease, it's difficult for them to, all they are doing now send to referral hospital far away, taking a couple of days or months to have the procedure done at hospitals. So by the system, so our government trying to focusing in each diseases. And for me and my colleagues there, we focus in cardiovascular disease. We stratify the access into four strata. First is in the public medical centers in districts, and then we call secondary referral center. It's in the region, and then one of tertiary medical center in the provinces level, and then national coordinators. So what we are providing under our as academic communities, we give advices to our government to prioritizing some medications, tools, so whatever in each of these stages. For example, in the public medical centers, we use screening tools, right? Blood pressure, diabetes, and doing what we use. Cardiologist knows well about the chart score to see in which area our patient right now, and then how to improve their health. And then
Diabetes and hypertension
yeah,
are key risk factors
yes.
in Indonesia.
Yeah, and then once they got screened, so we will have some people who already got the disease, right? And then they will send to nearby secondary hospital. We have 514 region right now. Our government provide this fund for distributing cath lab. Even now, MRI, etc. Whatever the technology needs to do in the way to prevent death For example, those with STEMI, heart attack, they have to be treated as early as possible. But the problem right now, it's easy for our government to provide the equipment, but to have the resources in terms of cardiologists, surgeons, that will provide.
Well, that was exactly what I was going to ask you, because Indonesia's got a number
Yeah.
of health priorities. How difficult is it to get the government to actually prioritize cardiovascular disease?
We did, and then they did. We are closely together, and then they provide fund for our doctors because limited places for fellowship, for example, for coronary intervention, they will send to nearby countries with our government scholarships. So, and also for the cardiac surgeon, they increase the number of cardiacs that will be placed in its provinces. It's working right now. We are speedily, increasingly the numbers, and then in the hope that this will work well to reduce the burden of heart disease. And right now, I would say to doubles number of hospital capability with cath lab, and double or triple number of hospitals that are now doing coronary bypass. At least that's
It's great. It's great to hear that you
Yeah.
and your colleagues have made progress. So I laud you for that. I know that there's a lot of challenges still ahead. Esther, let me come to you, because Spain has had a cardiovascular health strategy for a number of years, hasn't it? And you've made significant strides in addressing CVD.
Yes, thank you very much. Thank you.
It should be on.
Now?
Yes, perfect.
Thank you very much for inviting the Ministry of Health of Spain to this event. The Ministry of Health promotes the National Health System Cardiovascular Health Strategy that is the result of the work and consensus of a broad group of people and institutions concerned and involved in cardiovascular health. Integrates the contribution of the scientific association, health professionals, patients and families through the organization. The main objective of this strategy is to improve the level of cardiovascular health of the Spanish population, specifically through promoting cardiovascular health in citizens through the development of a comprehensive approach that facilitates the adoption of healthy and sustainable lifestyles and environments, reducing the incidence and prevalence of cardiovascular disease in Spain through prevention, improving care in the acute and chronic phase, rehabilitation and restoration of health, prevention of disability, and improving the quality of life and well-being of the patient and their families. Thus, the main areas of action identified as priorities in this strategy will be health promotion, disease prevention and early intervention, empowerment and citizen participation, knowledge management, research and innovation, equity and gender in cardiovascular health, and comprehensive approach to the person with chronic and acute cardiovascular disease. In conclusion, by way for summary, it can be stated that the most significant progress has been done in the following key areas. Achieving a broad consensus among all relevant stakeholders, establishing clearly defined framework of action under scientific evidence, recognizing cardiovascular health as a public health priority with targeted intervention for both primary and secondary prevention, structuring, addressing, and continuous working framework through the establishment of a scientific committee composed of representatives for both primary and hospital care. This committee holds the responsibility of advising the Ministry of Health and guiding a strategic decision aligned with innovation and emerging scientific evidence, and implementing comprehensive program based on following principles: governance, strategic priorization.
Can I, because I know you've got it written down and I know you want to go through all of it and it is really interesting, but what I'm really interested in hearing about is one of the things that Spain does really well. We were talking, Renan was talking about the remote islands that trying to reach. Clearly Spain doesn't have that problem, but you do have marginalized and under-resourced districts and people and populations. Tell me how your cardiovascular action plan reaches those marginalized and under-resourced places. How do you deal with access and equity?
For equity, for Spain is very important.
Yes.
Yes. In the ministry, we are they share in all our strategies the part of the equity. We seek to reduce inequalities in access to outcomes in cardiovascular health, especially in marginalized and underserved population.
Yeah.
Yes, it's our principal objective.
Absolutely, and I think there's a lot of lessons that can be learned there from other countries looking at the model that Spain has got.
The most effective initiative combines community-based prevention, resistance of material and intercultural mediators, guarantee access to essential services, treatment and addressing social determinants, always with an active participation of the affected population, in telemedicine and technology to reduce gaps and training to professional inequalities, inequities. Sorry. Courses in cultural competent health. Our strategy is moving in this direction, but requires further evaluation of impact on equity.
Brilliant. So innovation, technology, bringing in all stakeholders, all sections, including the patient voices, that it makes for a comprehensive cardiovascular health action plan. Thank you very much indeed, Esther. Great to get that perspective from you. Kuamivi, let's talk about the WHO's perspective. How do health plans align with the WHO's efforts to ensure cardiovascular health is integrated into universal healthcare strategies, for example, particularly in low and middle income countries?
Thank you very much. I hope you can hear me clearly. Firstly, I wanted to thank the World Health Federation for inviting WHO to this important meeting. And I think we cherish our collaboration, and we look forward, continue working together when it comes to tackling the high burden of cardiovascular diseases globally. So to respond to that question, I had the privilege to, go through the draft framework by the World Health Federation. And like the 9 key components mentioned by Finn are quietly, directly aligned with WHO recommendations. So if you allow me, I will just go through them very quickly. Yep. So number 1, the framework mentioned governance and leadership to ensure that we have political commitment and strong collaboration for cardiovascular disease prevention and control. So as you know, WHO, for us, political commitment is key, because whatever you implement in a country as a strategy, if you are not able, to get that commitment, you will not have a sustainability of the implementation. So I just wanted to give an example. If you look at Ghana, for instance, in Africa, WHO supported the country in year 2022 to improve prevention and management of NCDs with an emphasis on CVDs in the country. And that leads us to what we call the WHO Global Compact on NCD prevention and control. And we've been able, through the discussion with the high-level leadership, to gather what we call the head of state gathering led by the president of Ghana. And that was one of the critical point when it comes to advocating for NCDs prevention and control. So you'll see that Ghana's national strategy has that huge component focusing on CVD as a main contributor to the burden of NCDs. So I think second is the risk factors prevention and health promotion. And we know that WHO is supporting member states to implement, tobacco-free taxation and also tobacco taxation, alcohol and sugar sweetened beverage regulation policies through our packages like, the Empower, the Shake, the Replace. Those technical packages are aligned with this framework because we are encouraging countries to take action so that we can prevent, cardiovascular diseases and NCDs as a whole. And the third one will be screening and early detection. So screening and early detection is critical because in low and middle income countries, you will see many patients will come to the facility only at a very late stage, where it's very difficult to get access to quality care. So WHO technical package, the hard technical package mentioned by Finney's presentation is key to help at lowest level of care to screen, diagnose, and manage the major risk factors for cardiovascular diseases.
Yeah, I think what you're saying is really important. I think you've hit the nail on the head, that it is obviously a no-brainer that prevention, that detection, that early detection, screening, those are absolutely key in trying to win the battle against NCDs and then managing and tackling strengthening primary healthcare systems. But that is a challenge for a lot of low and middle income countries. But the WHO does have tools in place which can help them embark on their NCD and more specifically their CVD action plans.
So in terms of the specificity of the CVD action plan, if you look, we have what we call a framework for developing national multi-sectoral action plans. At WHO level, we encourage countries for integration, not silo-driven action plans. However, when you go to the main NCDs, we know that cardiovascular diseases are critical, are important. And if you look at the steps recommended by WHO from the assessment level through the implementation level, you will see you have that place that you can give and more important to cardiovascular diseases because of their burden at country level. And this is tailored to each country's particularity. So we hear the figures about how many countries have NCD action plans. We are more talking about multi-sectoral action plans. Then this leads us to go above or beyond the aspect of only NCDs, but have a plan that brings specificities, CVDs, chronic respiratory diseases, diabetes, and we know the interplay between these conditions. It is not a reason to overlook on cardiovascular diseases, but give more space to prioritize CVDs and at the same time create the connection with other NCDs as well.
Right, okay, so a more integral approach with other NCDs. Thank you very much indeed, Komivi. Neil, let me come to you. I know that the Global Heart Hub is a key partner of EACH, the European Alliance for Cardiovascular Health. Now that is trying to put into place a European-wide cardiovascular health action plan, which is a really ambitious project. Not least because you're trying to get all the European countries to agree on a common set of principles. But how is that going to achieve a coordinated approach across Europe to reduce premature deaths from CVD?
Before I answer that question, can I just make a comment relative to something that's been said already, prompting me the need to highlight that if countries are thinking about cardiovascular health plans and they're only thinking about hospitals and infrastructure, they're missing the key opportunity here. Because once somebody becomes a patient, we have missed the huge opportunity which is out there to prevent that from happening in the first place, because we know so much of this disease is preventable. So central to any cardiovascular health plan has to be a primary focus on prevention across primordial, primary and secondary prevention. So I just want to say that in terms of any discussion on cardiovascular health plans. in the context of each, the plan is not over the line yet. And you can imagine that, it's close to it though, I would say. And what has been quite transformative actually in getting to this point is the establishment of EACH. And what EACH is, it's an acronym for the European Alliance for Cardiovascular Health. And I think what's interesting about it is, I believe it's the first time that you have a cross-sectoral alliance focused on cardiovascular health. And in that alliance, you have the clinical societies, you have industry, pharma, med tech, you have civil society, you have patient groups, and you have basically a very united community who are really focused on trying to communicate to our policymakers the urgency and the necessity to address cardiovascular health. And a real sort of eye-opener for me was, and what actually, I would say, escalated the movement of this plan, was the EACH Alliance hosted an event at the European Parliament where they sought direct contact with parliamentarians and sought their support to pledge in the incoming Parliament to bring cardiovascular health up as a priority issue. And what really opened my eyes there was the power of the civil society groups and the patient organizations who actually mobilized their local parliamentarian under the pressure of local vote, local action, to go and sign on.
So advocacy made a
Critically
real
important.
difference there.
Critically
And I suppose it also, not just to get a plan in action, but the shape of the plan as well and what it should cover.
So in the shape of the plan, again, this is what's, I think, very significant. The plan, or at least the roadmap that has been offered up to the Parliament, has actually been developed by the Alliance.
Right.
So the good thing about that is, and I can say as somebody representing civil society, I know that our voice was heard in the development of that roadmap. And I think that's very important. And so you have civil society, patient voice, clinical community, industry. And interestingly, in the cardiovascular landscape, one of the missing pieces of the jigsaw is actually bringing all the stakeholders together. For some reason, there's this idea you can't talk to industry, or you must keep the doctors away from the industry and from the patients, when in actual fact, we all need to be sitting at the table on this discussion. And the most important person at the table, actually, is the citizen who is at risk or the patient who has a diagnosis. Because they're the ones, they're the end game, and they need to be there.
So, I mean, absolutely, yes. I was going to say, I thought collaboration was something that we all instinctively saw as a way of making progress. But you're saying that actually there is still a bit of reluctance to bring other stakeholders to the table, which is astonishing.
Yeah, historically and currently, there is definitely a sort of a sense of you can't have patients talking to industry and you can't have industry talking to clinicians, or if it's done, it's to be done of course it has to be done carefully. But the bottom line is the solutions to this problem lie in a united, collaborative effort. And the answers to the problem are there. We know the causes of cardiovascular disease and we have largely great treatments, but what's missing is a political commitment. Now that brings us to another issue, which is why are we missing this political commitment? Why is it that when I entered this world of patient civil society 35 years ago and I knew nothing about cardiovascular disease, I read up and I heard that from the literature that cardiovascular disease was the leading cause of death and disability in the world. 35 years later, it's exactly the same.
Yeah.
Okay? Now, we have made significant improvements. Obviously, we're less people having heart attacks, or when they have a heart attack, they're surviving. But what's the value in surviving a heart attack if you live 20 years with a significant level of disability and comorbidity? The key thing needs to be act earlier, identify those risk factors, early detection, early diagnosis, early intervention. But when you get down to policymakers, what worries me is that when you speak to policymakers, these are the people that are going to be making decisions about how to prioritize cardiovascular health. Their perception of cardiovascular disease is a little concerning, because I think there is a sense that that cardiovascular disease is largely about lifestyle. It's not largely about lifestyle. It is a significant part to do with lifestyle, but there are also factors outside the individual's control, not modifiable risk factors that need to be looked for, identified, and intervened or in a preventive way at a much earlier stage. So we really need to have a paradigm shift in our thinking about cardiovascular disease, and really move away from this idea that it's inevitable, because it's not,
Yeah.
and put a far greater focus on trying to look at the known risk factors and take very clear strategic measures to systematically address those throughout the life course.
Okay, I'm going to pick up on a couple of the points that you've said there with our other panelists. So let's start with this idea of collaboration and partnerships. Renan, this is something that maybe has some greater focus in Indonesia, because obviously you were talking about the challenges in covering cardiovascular disease across the totality of the islands and your nation. What partnerships and collaborations have proved useful for you?
Yeah, I agree. Partnerships is very important. I mean, for every factor, every single entities, right? Both NGOs, academics, and etc. So it's been set up many times. We work together. We have a program, etc. But but still, so we already know the risk factor of cardiovascular disease, right? So we work to prevent tobaccos. There are lots of rules on prevention of people from smoking, right? And also reducing salt, etc., etc. But still, there are some facilities needs to detect those with risk factor, right? So to tackle that, even early this year, our government launched a probably unique program, I think, mandatory general checkup.
Mandatory general checkup.
On birthday.
On your birthday?
Yes.
Any birthday or?
So somebody's birthday, then our system will inform them, please come to nearby medical center, and then you will be checked based on your age group. Okay?
Sounds good.
For example, for childhood, they will have some infection and the things including the status, nutrition status, etc. And for adulthood, they have to be checked for hypertension, blood sugar, cholesterol, and it's free.
That's quite an undertaking.
Free.
Free. That's
Yeah. So
brilliant.
by then, right now, millions of people already got. We get the data. Interestingly, we have some things to do with the data, right? So we have a real data on the public. So how the burden of hypertension, the diabetes, dyslipidemia, etc. So we work on that. So our government tried to buy this real data, whole country, everyone's data. Then in each single group, then there will be some action plan on prevention.
Very impressive, thank you. I want to pick up on another of Neil's points and talk about political leadership. And Kumivi, I'm going to come to you first, and then maybe you, Esther. There's a lot of uncertainty about the future of global health right now. WHO is being reorganized, financing's declined. Now more than ever, we need political leadership in the sphere of NCDs and CVD health. How do we encourage that? How do we encourage policymakers to look at cardiovascular diseases and take action on it?
Thank you very much for that question, a tough one. I think, yeah, you're right. We are in a critical moment. And what I want to say is the time is no more for talking. I think we need to start acting. And this is exactly what WHO partners need to raise before governments and political, representative at the UN high-level meeting on NCDs. Because, we know exactly what we need to do. We know how to do it to prevent NCDs, to prevent cardiovascular diseases and manage them. We have the capacity, we have the knowledge, but what is missing is a will from policy level to implement that. How do we make sure that in our countries, when we talk about health benefit packages, especially in low and middle income countries, cardiovascular diseases are taken into consideration? Availability of the medications. How do we use taxation to finance implementation. So I think those are the key messages we need to raise to representatives from government at the UN High.
So governments can look to see what actions they can take themselves, like the sugar tax that you were referring to. Esther, I think given Spain's success in integrating cardiovascular health into national policy, how important is political leadership? Clearly, you've got strong political leadership in Spain when it comes to health policies, but also, what recommendations would you give to other countries looking to implement a cardiovascular action plan?
In our experience, it's very important to improving health outcomes in equity and sustainability of the national health systems, to fund prevention and treatment programs to improve quality of persons, promote efficiency in the use of resources through digital technologies and telemedicine, increase autonomy and empowerment of stakeholders, develop support and empowerment programs for patients and their families, promoting self-care, and encourage cooperation between different levels and disciplines of healthcare, creating multidisciplinary networks, improve of social and professional process, to support programs to promote healthy lifestyles through grants and campaigns, fund projects to ensure continuity of care for patients with comorbidities, and establish a patient safety standard and best practice at the European level, promote research on gender difference in cardiovascular health, ensuring appropriate diagnosis and treatment for women, facilitate cooperation between sectors to promote healthier environments, and training, research, innovation, and knowledge management, provide continuous training programs to health professionals in cardiovascular disease, and invest in infrastructure of resources needed to treatment and care.
I love that. One thing that you said, you read very quickly, and I thought, that is brilliant, looking at cardiovascular health from a gender perspective. So looking at it from a woman's perspective, I love that. Just a quick word about your prevention that you have, your lifestyle information and education. Is that something that involves other departments across Spain? Are you looking at, is education involved in that? The schools? I mean, where are you aiming your prevention strategies?
Yes, now we have another strategies that from the life course of life, from the child and the gender is shared in all the strategies in the ministry. To improve the lifestyle, the health meal, something like that.
Yeah, eating, diet, exercise, all of those things, which brings me back to Neil's point about, we can avoid a lot of the problems that come with cardiovascular disease, but it does need that integrated approach, doesn't it, Neil? And I wonder what elements you think, including the patient voice, are absolutely non-negotiable when it comes to cardiovascular health action plans.
Well, I think what needs to be non-negotiable is that the voice of lived experience and civil society need to be at the table. They need to be at the table in terms of developing the plan, because ultimately it's going to be those individuals or their families and all of us at some point, who are going to need to benefit from this. And ultimately, it is Joe and Mary Citizen who votes for our policymakers, So again, in terms of holding policymakers to account, if you don't have citizens in the equation and patients, people with lived experience, I think there's a missing piece of the jigsaw there. But I think ultimately what you're looking for is what is required is a clear political commitment to address the challenges that we face. And I fundamentally think that part of the problem, as I said, is that we have a cultural mindset that needs to be shifted. Fundamentally, I think that people are talking about, for example, that the health service needs to be reformed and made fit for purpose, and that is true. But I actually think it's our education system that needs to be reformed, because in our education system, if we start at the very beginning and if we instill in our citizens the value of health and encourage healthy lifestyle, proactive maintenance of health, understanding of risk factors, knowing when to, get your cholesterol checked, get your blood pressure checked. And all of these, actually in the context of cardiovascular disease, all of this actually detection across the risk factors is all low cost. You can check your cholesterol, your Lp(a), and your HbA1c with a finger prick. You can detect blood pressure with blood pressure monitor. You can check. You can detect atrial fibrillation from a pulse check. You can identify aortic stenosis from a stethoscope check. These are all non-invasive, very inexpensive technologies. But what we're missing is a systematic application of these across the life course.
Just to play devil's advocate, because that's what I like to do. Kumivi mentioned that there are plenty of things that governments can do to encourage healthy lifestyles. He mentioned a sugar tax, for example. That kind of nuclear option, though, is often not taken by policymakers because they want to maintain relationships with food manufacturers, for example. So getting them over the line, getting them to do something like that, which is probably counterproductive to their instincts, is quite difficult. I think that's where patient advocacy and civil society comes in, to put the pressure on governments to do things like that.
Yeah, and of course there are enormous vested interests, and of course it is very complex. But ultimately, what it boils down to is the people in power, the people who can make the decisions, is ensuring that we can get to them and convince them of the value of cardiovascular health. If you take, for example, in Ireland, a very brave politician who is now currently our Prime Minister introduced the first public smoking ban. And he went out on a limb because he was taking on the industry, and he was also operating in an environment where the majority of the population were smoking. So if you were talking about trying to gather votes, this wasn't a very clever move. Yeah. But actually, it turned out to be, we turned out to be a leader in the space, and many other countries followed. So you actually do need somebody with commitment and belief and nerve to actually make the hard decisions and stand up for what we need for our society.
Here. I'm going to invite questions from the audience now, because I think we've had a great overview of what the challenges are and what the value of a cardiovascular health action plan would be. Does anyone have any questions for our panel? Yes, lady in the second row. I think there's a microphone coming to you.
Hello, my name is Bronwyn Hennig. I'm the director of the Global Health Policy Lab, situated in Berlin, but spreading across the world. My question is around the moving from a framework to political action. Mm-hmm. So, frameworks are great, and there are quite a lot of them on all sorts of topics, etc. But then getting those frameworks anchored in legislation in a country, how do you, and I'm looking at the health minister of Spain in this, because you clearly have had success. But I wonder whether there's some sort of more concrete tricks of the trade to accelerate that, and how also then collaboration comes into this, of countries working together to say, okay, we've done it this way, or this is our framework that we started off with, and this is how we translated it into a policy that is now anchored in legislation?
Great question. Thank you very much. So Esther, let me ask you, how did you move from the idea of a cardiovascular health strategy to an actual policy embedded into your national legislation?
Because we have a national councillor with autonomous regions,
Right.
and with all these regions, we have share the politicians, and we adopt in common all the strategies, all the plans, and is shared with all country, in all statement in our country.
So there's a mass consultation.
Yes.
Everyone's asked for the best strategies.
Yes.
Why were your policymakers so happy, for want of a better word, to put that into practice? Because it must have cost a lot of money.
Yes, it's very cost for our ministry in general, but the autonomous regions, the social servant and the civil servant, the scientific have the possibility to share our budget in the ministry, and is shared for all the communities, and is for all the autonomous regions.
Renan, do you have perspective on this? Why is the government of Indonesia so keen to do something about CVD? Is it, I think Janelle from MSD said, it's an investment. It shouldn't be seen as a liability, because investment in reducing cardiovascular disease mortalities is an investment in your economy and your productivity. Is that how Indonesia sees it?
That's true. So our government, especially Ministry of Health, tried to tackle all these NCDs actually, as mentioned to you, not only cardiovascular, but also cancer, five priorities. In part of the transformation. So, as the pillar of transformation, this has to be seen as part of created better future for the country. So not only adulthood, but also for child. So this program also including detecting childhood with congenital heart disease, for example. So we try to create the future. The better future for our generation. And even now, our government also tried to increase the health, the nutritional status for our childhood. We have program a free lunch in the school, just launched. So every school every student will get free lunch.
Obviously a low fat, low sugar.
Yeah, that's true.
Lots of fresh veg.
So the natural facts should be there. So our government will try to improve that also from beginning. So the commitment of government is very important. Collaboration in the academic is very important. So all aspects have to be improved.
You make it sound very easy, but I want to get other views about how you go from strategy to policy.
I think this is the most fundamental question, because paper doesn't refuse ink, and there's been policies and documents and so forth. I think the elements of this are, first of all, we need an alliance of the critical stakeholders, an alliance of influence. Then you need active advocacy, and then you need accountability. And the accountability piece is sometimes also underestimated or undervalued, in that sometimes we get to a point where there's a policy and there is some funding or resource around it, but actually then there's no accountability. nobody's being held to account. And that's why I think civil society has a huge role to play here, because ultimately civil society is who holds the policymakers to account, and we need to activate that. But it's right across the whole healthcare system. So within, say, for instance, hospital systems, there needs to be accountability. Within healthcare, there needs to be accountability. For example, you have the best minds in the world in the management of cardiovascular disease setting clinical guidelines of best practice, but those guidelines are not being adhered to. So, and where's the accountability on that? Like, who's holding who to account?
Yeah, it's an interesting question. Thank you. Thank you for your comment. Lady in second row in the red headscarf. Thank you.
Thank you for this great panel. Very interesting success stories and way of thinking. I just want to share my learnings because I'm sorry, I didn't present myself. I'm Dr. Amifal, I'm a medical doctor, and I'm the head of medical for Global Health Sanofi, Global Health Unit. And I'm working in 40 countries, 14 in Asia, 25 in Africa, and Haiti. And I'm talking about, in the perspective of having been a medical doctor, a clinician in low and middle income country, being a patient also. I have hypertension. I'm a survivor of pulmonary embolism, and I have sickle cell, so I know what I'm talking about. I have spent 30 years in civil society. I'm still in civil society in my country, pushing, doing advocacy. Mm-hmm. And I have spent 30 years, exactly 29 years in the pharmaceutical industry, pushing countries for more engagement, working with...
Have you got it? How much progress
I will
have you
arrive
made?
on that. I have the habit working with professional societies, association. I was the president of Women Medical Doctors in Senegal for 4 years. Working with patient associations, working with NGOs, actually 10 years in global health, in the field of global health, working with NGOs, with government. And my conclusion is that it's all about leadership.
Yeah.
We can say what we want. We know everything to do. We know the gaps. We know how to find solutions. We know what to do concretely. But at the end of the day, the one who have accountability and can move the middle is at national level. It's government in countries who should have the leadership, bringing all stakeholders together in a country, knowing exactly what's going on in his own country, having his own strategic plan, asking to all partners to align with his own action plan because he knows what he needs in his country, knows his population, and knows also should have all the data needed to have a great strategic plan and push everyone to go in the right way and to do things. And I think that we have very nice success story in a lot of countries. I have an overview with many countries, and I can tell you that great things have been done in some countries. Okay. We need to leverage on this and try to build something.
I think that's about a great point. That's a great point, and I think talking about progress is. Kumivi, I'm sorry, I'm going to put you on the spot here. Have you seen progress to an acceptable scale when we're always talking about having to reduce the need to reduce CVDs, the need to tackle NCDs? Have we seen enough progress?
Yeah, I think we have seen some progress in few countries, and this is a kind of hope that we can still, improve prevention and management of cardiovascular disease. We are talking about prevention, policy actions, different NCD risk factors. The problem in our countries, you know that have health ministry, have economic ministry, have commercial ministry, and each of them, they have their own purposes. So
But they all benefit. They
I
will
know.
all benefit.
We know that.
If
But
we
the thing
reduce
is,
those
if you want to talk to
mortalities.
government and then you focus only on Ministry of Health to talk about the taxation, then nothing will happen. So as the colleague was saying, this is something we need to bring like more like an upper level in terms of engagement. In countries where we've seen some successes, you will see there is what we call multi-sectoral steering committees, led by maybe Prime Minister or even the President office. So bringing together different ministers, parliamentarian people, people living with NCDs, private sector, health bodies, and then to discuss together, okay, why do we need this? And years back, WHO and UNDP has developed some documents. If you go on Google, you will see it's a message for health minister, message for sport minister, message for industry. So this kind of targeted messaging help countries to understand, okay, you need that money from the company, but why do we believe you will gain more if you do prevention? So those are some of the important aspects of how do we work as we can bring this as a leadership level when it comes to commitment from government and leadership. Yeah.
Does anyone else want to comment on progress or lack thereof? Because I think it's really interesting that Finn made the point that we were talking about CVD being the leading cause of death years ago, and it's now still.
Yeah, one thing on progress, and people will say in the cardiology world, that we've made great progress, for instance, in the treatment of acute MI, which is fantastic, and we have. But there's also a downside to that, and that is that we are now saving people from heart attacks, or we're preventing heart attacks, but we're not actually addressing the disease. And what we're ending up with is a lot of people post-MI living long lives, but in very poor health. So the metric needs to be much wider than just mortality. We need to talk about quality of life and functionality. And so that's one thing I would say in the context of progress. The other downside, I guess, at a practical level, going back to the piece about mobilizing the citizen, is that, again, when I entered this world 35 years ago working with heart patients, it was at a time before the great advancements in PCI and so forth. And people had a heart attack and they spent maybe 2 weeks in hospital, and they came out and they were very fearful, and we coined the phrase, cardiac cripples. They were very protective of themselves and slow to get back to work. Today, and I meet these people, and they have an MI, and they're on the table in 90 minutes, they're stented, and they're back in their desk at work in 48 hours, and they think, this is great, I'm cured. Yes, your life has been saved, but the underlying cause, the atherosclerosis, has not been addressed, and this is something that needs to be managed. And that's why we have so many of the sort of revolving door of second and third MIs, because the message hasn't got through that this is a disease and it needs to be managed.
We're coming to the last few minutes of the panel discussion, and I want to just hand the floor over to each of my speakers to ask for what they want to see next in this coming September. We have the 4th high-level meeting at the UN on NCDs, and I would like to know what you want to see from member states regarding national CVD action plans and strategies. Renan, why don't I start with you, and please keep these short.
Yeah, I think a collaboration between countries is very important. So accessibilities, especially I'm coming from, I would say medium-income countries, so some accessibilities on the medication or infrastructures is still problem. So we have our national coverage program, including all people, but only limited package on each diseases. So having a more affordable medication and devices for heart disease, even for some reagents here to detect diabetes, etc., is very important. So collaboration in that to all the countries throughout the world is very important.
Collaboration and innovation, great points. Esther.
For us to have a clear political and financial commitments, it's very important to increase public investment include CBDs in cross-sectoral agendas, economy, urban planning, agriculture, to address determinants such as air pollution and war-related stress, and to have an equity-focused plans, primary prevention with public policies. I can speak a lot.
No, I think you've made it clear. Clear financial commitments and a focus on equity. I think you've put it brilliantly. Thank you very much indeed. Kumivi.
Thank you very much. I think in addition to a clear commitment from leadership, we need also to have accountability.
Yeah.
It's very important that this time we shouldn't just, raise issues and just leave, but people should be accountable on exactly what they have decided to do in their countries, leveraging on the existing we've been able to achieve so far, learning from each, other countries which are doing very well, and then try to improve access to care for CVD.
Accountability. Brilliant. Thank you very much indeed. And Neil.
We saw when the COVID crisis hit that there was a political will and unity to do something, and it was done very, very quickly. This is an equally, I would argue, urgent health issue for the world. We need political commitment with adequate resources, and we need realistic targets and objectives. And on the question of accountability, it's probably the wrong place to mention Donald Trump, but I will say that when he went up for election, he said he was going to do certain things. And he's probably the first politician in the world that is now doing what he said he would do. So if we could get politicians to make a commitment to cardiovascular health and to do it with the same vigor, not necessarily the same methodologies, but with the same vigor, I think we'd be looking at success down the road.
Absolutely. Neil, thank you very much indeed. I would like to, we've obviously all got high hopes of the UN meeting in September. I'd like to invite all of you to join us for some refreshments, for a little networking. Let's talk about how we keep CVD at the top of the agenda, maybe bring Donald Trump in on our campaigns. That might have some success. But let's end by giving our brilliant panellists a final round of applause. Thank you.